Okay, so we're back talking about intrauterine devices. We have Mirena, Skyla, and Paragard are three choices. They look like little T-shaped devices, about 1.5 inches long. Come in two types. We have copper, which is Paragard. It does not release hormones. It works by creating a mild inflammatory reaction within the uterus and disabling sperm. And we have the progestin-releasing devices, Mirena and Skyla. Mirena is more appropriate for people who have had children. And Skyla is a little bit smaller. It's more appropriate for women who have not had children. Their cervix has not been stretched, so it's a little bit easier to insert. It's a T-shaped device inserted into the uterus. I'll show you pictures of it. Works by thinning the lining of the uterus and creating a hostile environment for sperm. So they never get to the outer ampulla of the fallopian tube. If they do, they're damaged and they cannot penetrate the ovum. Hormone-releasing IUDs also prevent ovulation. They do not interrupt an existing pregnancy. They don't cause abortion. It's important when they're being inserted to make sure that the woman is not, in fact, pregnant. But some people have this sort of misconception that they work by sort of creating an abortion situation. It's not true. Advantages: there is no chance of user error if it is inserted correctly by a licensed independent provider who has been trained in the technique. It is good to go. It is completely reversible. And it is long-acting. Skyla lasts at least 3 years. It can actually have effectiveness beyond that. Mirena lasts at least 5, up to 7 in some cases. And for women who are older, it can last even longer. There is the Paragard, which lasts for about 10 years. Again, sometimes people leave it in a little bit longer. They should be removed and replaced at that time for optimum effectiveness. So Paragard failure rate is 0.8%. Skyla and Mirena are 0.2%. When we get to tubal ligation, you're going to see it's actually more effective than having your tubes tied. As long as the device is not expelled, which is a risk. Initially, this is a very expensive method. It's over $1,000 for insertion of a Mirena. I believe right now it's about $1,200, but much less expensive over time. You don't have to replace it for 5 years. Now, in most situations when people have insurance, this should be covered under the Affordable Care Act. Some people have exemptions from that because their employer has gotten out of that. But in most cases, it should be covered by insurance. It must be inserted by a licensed provider who is familiar to the technique. Not all family planning agencies can access this method. So because it's expensive, they may not have it as a routine thing. So it's not accessible to all women, although there is a push by the CDC to make it more accessible to women in the United States. Women used to be told, check for a string. There are these little, sort of almost like fishing wire strings, very thin, very small, to verify placement. It's really not necessary. If you have a day where there's a lot of cramping and bleeding and you see the device, then obviously it was expelled, but it really isn't necessary to check for it every month. Paragard, the copper IUD, does cause heavier bleeding and more cramping. The Mirena and Skyla, on the other hand, tend to alleviate cramping after the initial insertion period. That can cause a little bit of cramping initially, but about 20% of women will stop getting periods altogether with these methods that release the levonorgestrel, which is a progestin. The progestin does not go systemic, by the way. It's localized. It will prevent ovulation. With IUC placement, women should be screened for STIs. So you're putting a foreign body someplace. So if you already have gonorrhea or chlamydia or one of those, it's not ideal. It can lead to pelvic inflammatory disease. But if the woman does not have an STI, her risk is not higher for women who don't have an IUD or an IUC. There's a very small risk of perforating the uterus during insertion, more common when women have things like a tilted uterus, but it's small, and a properly trained provider will not perforate the uterus during the incision. And that's your intrauterine device. And we'll talk about barrier methods of birth control: male condoms, female condoms, diaphragms, caps, and sponges. Yay. Okay, so male condoms. Most of us are familiar with the male condom. Most of us had health class. If you were in a public school, you got this talk. It is a sheath that goes over the penis. Most of them are made of latex. Non-latex are a little less effective. They are actually made from animal intestine in most cases. There's one other synthetic material. I can't pronounce the name, but most of them are made of latex. They provide a barrier that prevents semen from entering the female reproductive tract. It's a very simple device. They've been available for centuries. They are widely available over the counter. Sometimes people give them out for free. You go to Planned Parenthood or you go to a public health fair, you might see these given out for free. They do provide some protection against STIs. It's not perfect. You should still counsel people about high-risk behaviors. But the other advantage is that they allow the male partner to take responsibility in family planning. And they can also be used not just in vaginal intercourse, but in other types of sexual activity as well to prevent against the STI. Disadvantages: adherence is poor. That's why there's an 18% failure rate. They can break, they can slip, things can spill. So if that happens, the patient should be instructed to use emergency contraception. Latex allergy obviously is a contraindication. They can degrade over time. So check for holes, tears, anything that looks like the condom might be old, like a discoloration of the latex. And the patient should know that you don't use any petroleum-based products that weakens the integrity of the latex, cause little micro tears where semen can get through. And that's your male condom. Barrier methods of birth control: female condom. So there is a thing called a female condom. It's kind of funny looking. I wanted to attach pictures to this, but I also wanted to get it to you as quickly as possible. So if I get a chance to remake this, you'll see more images. There are two rings and then this sort of sheath goes into the vagina. The upper half goes sort of towards the cervix. The lower half is sort of outside the vagina. They look a little bit funny if you're not used to seeing them. Okay, so on this subject, a new female condom should be used with each episode of rectal or vaginal sex. So these were invented mostly for female sex workers in countries where women were getting HIV. It was very prevalent. And everyone thought this was a great idea. It gave the woman control over the barrier and allowed her to protect herself from sexually transmitted infections. What they were finding was, because they were expensive and hard to get, these women were rinsing and reusing. That should not ever happen. It's a little more expensive. It's a little more cumbersome. It involves touching the female body, and some partners may not like it. So that's the female condom. Then there is the diaphragm. The diaphragm has been a method that was much more popular for use back before oral contraceptives became more available. It is like this little saucer. Again, I'll get you guys pictures. It's placed in the vagina to cover the cervix. It does not protect against STIs, even though it is a barrier method. You have to use a spermicidal jelly. You put it around the ring. Then the device has like a sort of a flexible rim, has to be like kind of folded in, inserted into the vagina, and fitted against the cervix. So women have to be very comfortable with their bodies to use it. It has a 12% failure rate within a year. Some of this is due to the method itself, and some of it is due to lack of adherence to it. The fit should be checked if the woman gives birth, has a miscarriage or abortion, or gains or loses more than 10 pounds. So there are different sizes of diaphragms. They have to be fitted by a provider, so you need an office visit to do this. This is not a mail order type of thing. They should be replaced every 2 years. They should be inspected for holes, tears, degradation. Again, should not be used with latex, with petroleum-based products. They've decreased in popularity, but they are a good choice for breastfeeding mothers. They don't interfere with breastfeeding at all. If the woman is committed to using it and is comfortable using her body and will use it consistently. Now, if there's more than one active intercourse while that diaphragm is in use, spermicidal jelly should be reapplied. It can be left into place for up to 24 hours after sex. should be left in place at least 6. Then we get to contraceptive sponges, and these are great. They're over the counter, 2-inch round, little sponge. It's got spermicide in it. It's inserted very similarly to the diaphragm, has a little sort of elastic so that you can reach in and pull it out. 12% failure rate over a year. If you've never given birth, 24% failure rate in women who have given birth. It just won't cover that multip cervix as well. So this is really not a great method for women who have had babies unless they feel like having more babies in the future. Or if they combine it with a condom, they'll increase their effectiveness a little bit. Prior to insertion, you wet the sponge to activate spermicide. Insert it with fingers into the top of the vagina. Make sure it covers that cervical opening, the os. Again, woman needs to be comfortable with her body to be able to do this. It can be placed up to 24 hours before sex. Should stay in no more than 30 hours to decrease the risk of toxic shock. And that's your sponge. So those are our barrier methods and our IUDs.